Good evening, everyone. I am so happy to be here with you all this evening, and I'm so happy to be here in conversation with you, Dr. Malone. As stated previously, my name is Jonquilyn Hill, and I'm the host of a podcast from Vox called Explain It to Me, where we answer listener questions and are in conversation with them. So I'm really excited to be in conversation with you this evening.
Well, thank you, and I am excited for all of this because as I look around the room, I see a lot of young faces here, and this makes me very happy because you are going to get the most out of this conversation.
So we heard a little bit about the theme for MHHJ and its lore, the stories that we tell one another and how that relates to our health. I want to dig into the lore behind the term grown woman. What does it mean to be a grown woman? And in particular, what does that mean for you?
Well, you know, to be a grown woman, every one of us has sort of a different idea of when you are a grown woman. I thought I was a grown woman when I was 18 years old. I actually remember telling someone that, and she said, "What?" I said, "Oh, I'm grown." But the term really came from conversations that my mother used to have with her friends. And there were all these things that would go on, but then there would come a point in the conversation when, as a child, and you were watching, you know, your mother and talking to her sister and her friends, and she would turn to you and she'd say, "This is grown folks talk." And that was your cue to leave the room. But there are a lot of those conversations that happened outside of earshot that we probably should have at least heard some part of. And I think that was the point, to try to write and talk about some of the stories that we should bring out into the open, that we should not be ashamed. We shouldn't stigmatize things that are particularly things about our bodies. So that's why Grown Woman Talk came out, because I said, I want to bring all these things that were traditionally taboo and things that we didn't talk about from one generation to the other, and put them out there, and let's have this grown woman talk out here in the public forum.
I love that so much. There really is this moment over time where you kind of realize you are grown, and there are these conversations that you weren't necessarily in on, and maybe you'll talk with your mother or an auntie or someone older in your life, and they're just kind of like, "Wait, what do you mean you don't know that?" And it's because we didn't have that conversation. What does it mean to be a grown woman when it comes to healthcare specifically?
You know, to be a grown woman in the healthcare environment really means that it is not someone else's responsibility to take care of you. And I think when you're a girl, when you're a child, it's your mother's responsibility. And for many of us, even as adults, we sort of came into this relationship with our doctors thinking that our doctors were going to take care of us. But I'm here to tell you that that is no longer really the dynamic in doctors and patients. You are now responsible for taking care of yourself and for managing your own health care. And that is where you really cross that line when you say, okay, it's not anyone else's responsibility, it is mine, and I now have to approach this as a grown woman.
I feel like that sounds very daunting, but it can also be really empowering.
It should be very empowering, because I think that we all want to have agency and to be able to take care and advocate for ourselves. The problem is many of us don't know how. And the reason that I wrote the book, and I spend a lot of my time not just taking care of patients in the office, but I am often the navigator and the source for my friend group, for my family, for friends of friends, because it became abundantly clear to me that whatever's going on in the doctor's office, there's a lot of stuff even in that conversation that either doesn't get said or certainly not understood. And I think when we approach this relationship as being a patient and a doctor, there is sort of an inherent power imbalance in that relationship. And what I'm here to tell you is that that's got to stop. And when you become a grown woman, then you deserve to have a conversation with your healthcare provider, be it a doctor, be it a nurse practitioner, but you should be talking at least, not that you're at the same educational level or knowledge level, but you should be able to be spoken to with the same respect, and you should be able to be seen and to be heard the way you would in any other aspect of your life.
I think something that's so interesting is that as women, I think we often care for others at the expense of caring for ourselves. And this book really serves as a roadmap to say, okay, this is a way that you can put yourself first, that you can care for yourself. Was there a particular instance that inspired it, or was it a number of different things? What inspired you to write this book?
Well, I have to tell you, I am, first off, to give you an idea of who I am and what my life story is, I am the youngest of 8 kids. I'm born in Mobile, Alabama, and I'm the youngest by a lot. My oldest brother is 23 years older than me, so I have a brother who's 88. So to give you an idea of our experience with healthcare, it starts with my parents. My mother was born in 1914, so let's do this math. My dad was born in 1893. They were both born in rural Alabama into a situation, these are, black people on a farm in Alabama. They had no real relationship with a doctor because there was really no doctor to have a relationship with. And their view of interacting with any sort of doctor was always under a circumstance where it was something very dire. You didn't just go to the doctor just to be going to the doctor. It was expensive. It was hard. My goodness, they had horse and buggies you had to get in those days. And nothing about that relationship with a doctor for black people in rural Alabama was ever anything that they ever wanted to repeat. It was usually associated with trauma. At the end of this interaction, it usually meant somebody died. So when they had their children, and we finally, my parents moved to the big city of Mobile, Alabama, they didn't have that experience. Nothing about interacting with a doctor was pleasant. I'm most certain that they never felt respected or cared for. And so we weren't raised to interact with doctors in a positive fashion because we never went. My mother would laugh. She was like, why on earth would you go to the doctor if you're not sick? Prevention wasn't a thing. So as we grew up, I learned to respect that ancestral knowledge, the knowledge that was passed down from generation to generation, because my mother knew how to treat a lot of things. And it might have been home remedies, it might have been, something that her aunties or her mother showed her, but she was able to raise 8 kids successfully. I think I could count on one hand and have fingers left over the number of times I actually went to the doctor. But there are things that common sense can't solve for you. And it is this, there's a point at which you have to realize that we have to interact in a way that is proactive, not reactive when there's something terrible going on. And, I'm forever sort of changed by the experience. I lost my mother when I was 12 years old, and she was only 57. And now, when I became an adult and I realized that my mother died of colon cancer, something that everyone now should expect to survive if you know what the signs and symptoms are, and 2, you have access to health care, and you know what regular screening is. None of those things did my mother know. And that was sort of the lived experience of people of her generation. You interacted too late. Very often, those sort of interacting too late stories were the things that fueled some of the myths that we have that you might have heard even from your grandparents today about, the things where they would say, don't let them cut on you, because she was fine till she had that surgery, and then the air hit it, and that cancer spread, and it's sort of like, Well, okay, I can see how, two things can be true. She did have her surgery and she did die shortly thereafter. But I assure you it wasn't because the air hit it. It was because we wait too late. And we don't have healthy relationships with healthcare providers. And that is what sort of fueled this whole book in terms of trying to explain to people, these are the things, as a grown woman, you should know. And there are a lot of them. And there's some of them that are just logistics. How do you even pick a doctor? What's important? How do you assemble a team? What's important, what's not about your health history and about your family history. These are the things that are just the basic framework before we even get into any sort of conditions that actually affect women in midlife. And that's important for all of you because we are living in a time now where medicine has changed. And for people who are in my generation, I think that we feel it most acutely because we knew it when it was another way, and now it's something else. And so we're kind of lost and adrift in this whole thing about trying to figure out how to navigate a system that was never created for you and never really, took into account who you are and how and what these things mean to you. And that's sort of the genesis of the book.
It's really interesting because you tell that story about your family and it feels so familiar to stories I've heard in my family. I lost my grandmother to cancer, and I remember one of her brothers said, "Oh, it's because you're going to that doctor. You shouldn't be." And I wonder how you think of the marriage between the lore of the past, where there is good, and we were able to take care of ourselves in certain ways, but also there's modern medicine, and you do need to figure out your blood sugar and your blood pressure and all these different things. How should we reconcile holding those two things at once?
Well, one, I think we should recognize the wisdom of elders because it's not nothing. They did get to this point in life and raise you. They weren't just, making stuff up as they went along. So we can acknowledge that, but we can do two things at once. We can acknowledge the elders and understand that maybe there's a different way of doing this because we are the first generation, my generation, I think, of women who think we know more than our mothers. It used to be the other way around. Your mother would tell you, and you're like, "Oh, no, Mom, don't put the baby on its back. Oh, Mom, don't do this." We've got a whole thing because we sometimes go too far in the other direction. And what I'm saying is that there should be some marriage between common sense, that's important, and being able to judge for yourself. And because, let me say this, not everything is an emergency. And I actually spend some time in a chapter in the book really explaining to you, okay, when do you go to the doctor? We sort of go through, all right, this is how you pick a doctor, this is how you assemble a team, this is what's important about your medical history. But what kinds of things should you be able to manage at home on your own? If every time you got a sniffle or a cough or something hurt and you ran to the doctor, okay, so let me show my age here. The little fable about, Chicken Little, if every time you run and you're in there every 15 minutes, then what do you think is going to happen? Well, chances are you're going to get treated for something you probably didn't need to have. And the other thing is that you're going to not learn what kinds of things you can handle on your own. I think that it's important to know what the natural course of things are. So your first impulse shouldn't be, unless it's an emergency. And I do explain what things are that are emergencies, and you do need to go and see someone right away. But sometimes just learning to take a minute, take a pause, try some things, then you learn, okay, well, just because I threw up doesn't mean I need to go to the emergency room. You know, I mean, my mother had a very, very high bar, and that bar was probably too high. You know, your head would have to be hanging off before she'd make you go to the doctor. But there is something that we do learn about how to, again, take care of ourselves, because it's not everybody else's responsibility to take care of you, and that's how you learn, trial and error, and knowing what works and what doesn't work, and just taking a pause for non-urgent conditions, and I say this, of observing 24 hours, 48 hours, am I better, am I worse? If you're better, then you're like, oh, okay, well, I know, well, when this happens, I should take a Tylenol, or when this happens, I should take kaopectate. Whatever that thing is, and I give you some very practical advice. I try to give advice about when is it appropriate to go urgent care, when is it appropriate to wait for a doctor's office visit, when is it appropriate to go to the emergency room. And I think those are things that are very important. Otherwise, you're going to waste a lot of time, and you're going to waste a lot of money, and oftentimes you're not going to get any better outcome.
I want to talk about some issues that Black women in particular think a lot about. You know, we think a lot about hypertension. We think a lot about breast cancer. We think a lot about the maternal mortality rate, and those things do deserve attention. But what are some things that we should keep an eye out for, be on the lookout for, think about, that maybe flies under the radar?
Well, I think there's a whole chapter in there on what I call female troubles. And that was the thing, that was a word that my mother used to use when somebody would be sick or down or whatever, and she would say, well, you know, what's wrong with her, Mom? And she'd go, female trouble. And I was like, what is a female trouble, you know? But it's fibroids, you know, it is cramps, it's heavy bleeding, it is all those things that are really associated with women's reproductive tracts that we're embarrassed to talk about. That's why we don't call it, we don't name it, because, you know, we have been taught historically to be ashamed of the very things that make us women. And so I want women to know that we're going to talk about these things. We're not going to wait and close the door and whisper. We're going to talk about them, because I want all of you young women to be able to approach these things and to be able to advocate for yourselves and not feel ashamed or stigmatized or to think things are dirty or shameful. No, no. We deserve our own care. And I think that we also are really butting up against the notion that I've practiced gynecology for over 30 years. And I'm ashamed to say that in all the time of my residency and practicing medicine, that I never really knew the history of gynecology. I knew this. I knew that, you know, as we're doing our residency and you're in med school and you know the story, oh, J. Marion Sims, oh, he is the guy that's responsible for creating the field of gynecology. J. Marion Sims, okay, we have instruments named for him. We have positions in surgery that you say, put her in Sims, and we know what that means. I never knew the story of J. Marion Sims and how the field of gynecology came to be. So imagine, before the 1850s, there was no field of gynecology. Women were just, you know.
Which, that's wild in and of itself.
No, there was no field. You know, if you see these old history books, the women would go into the doctors and women would be fully clothed, and the doctor would turn his head and put his hand under a dress kind of thing, because women were so shameful and so dirty that why pay attention to that, right? Well, J. Marion Sims, for those of you who don't know, and that the reason I found out about the whole story of him was, most of you know the story of Charlottesville, what happened in Charlottesville and tiki torches and the like. But there were demonstrations about taking down Confederate monuments. And, you know, all this is going on in Charlottesville, and then that's Charlottesville, but then there was something going on in New York City. And in Central Park, there is a statue that is commemorating J. Marion Sims, the father of gynecology, who practiced in Montgomery, Alabama, my home state. And after he left Alabama, and this is in the 1850s, he left Alabama, went to New York, and founded the first hospital for women. And so that's why he is lauded as the father of gynecology. Well, here's the problem. The other part of his story is that these women that he practiced on and created this field of gynecologic surgery, he operated on enslaved women. And his job was to correct some of the birth injuries and trauma that these enslaved women had. They had probably been having children too young. They probably were malnourished. They had difficult deliveries. And remember, there's no such thing as a C-section. So if you got pregnant and you could not deliver that baby vaginally, you would labor until one or both of you died. And when these women finally could deliver these babies, sometimes they would have horrific injuries. And these injuries made them not well suited for more reproduction. And that was the value of black women, enslaved women, was your ability to reproduce and create. So he had this idea of like, I think I can fix that, and so let me operate on these women. Well, the problem is he operated on women without anesthesia, needless to say without consent, because there was no such thing that women could consent. And he did it, he operated on these women in public, in front of other people. I mean, just no shame. I mean, very disrespectful to these women. And this is the man that we lauded and held up as, oh my God, he's the father of gynecology. Well, we need to know the whole story. And that's sort of how, if you think that's how gynecology started, just understand that there is nothing about the field that I would say up to present day that has been specifically designed for you or for your comfort or for making sure. It is just, that's our history, and we have to at least acknowledge that. And so that is why, as I tell the stories throughout my book, I tell family stories, I tell some, sort of composite patient stories, because I want you to understand why we are where we are. Women and women's health generally we've been underserved, we've been under-researched, and when it comes to women of color, then then it's an order of magnitude worse than it is for women generally. So we have to acknowledge that so we can do better.
When it comes to the racial health disparities, they don't pop up out of nowhere. And there's so much that causes them, that exacerbates them. I love to ask people this question, especially when it comes to policy, but if you were able to wave a magic wand, make the things that you think would fix the way things are happen, what would they be, both from the patient perspective and the practitioner perspective and systemically?
Well, there's a lot.
I realize that's a very big question.
But I say there's a lot that needs to be done systemically, because let's be perfectly honest. Medicine is taught from, I'd say more or less from a male perspective. Researchers are overwhelmingly male. The studies that have been done that on the medications and the procedures that we employ today have basically been done, that the research has been done on men. And then we've just extrapolated down. We said, well, if it works that way for men, it must work that same way for women. And I think that one of the first things that we can do as women collectively is to understand that the disparity in the research about women's conditions is worse than you think. When I wrote the book, and I had figures as of 2022, the National Institutes of Health, which is a major funder of research, of medical research in this country, had a annual budget of $45 billion. Do you know how much of that money went to conditions that primarily or exclusively affect women? Less than 11%. Now, we're 51% of the population, 60% of the voting population, and yet, when it comes to our taxpayer dollars, we are underserved and under-researched. Well, most of us didn't know that. I didn't know it. I didn't know it was that bad. But now you know, and that this is an opportunity for us to be able to say, well, then we need to be able to advocate, because we can't keep asking the same questions over and over again and go, I don't know. Oh, the maternal mortality statistics, you know, they're 2 to 3 times for black women than they are for white women. Well, they're worse for all women in this country than any other comparable westernized, industrialized nation. Why is that? Well, we keep describing things, but we don't do anything about it. And there's a lot about what fuels these disparities that we do know, but we choose not to. And that's a matter of policy. And that's where it really takes us all to be advocates, not just for ourselves individually, but for women collectively. And I think that when it comes to including or demanding that when these trials are done, and it was only until 1993, that it was mandated that women be included in clinical trials. Prior to 1993, it was like, okay, we'll do it on men. If it works on men, it must work on women. And that's just not true. Our physiology is different. Our hormones are different. The way we respond to medications, and even the sizes of some of the mechanical devices, the heart devices, the knee, the joint replacement, all these things are not designed for us. So we need to fix that. And when it comes to black women in this country, black and brown women, if I tell you that women are understudied, again, just imagine, black women are not traditionally included in studies, and a lot of researchers throw their hands up in the air and they go, well, we tried, you know, we put an ad up and nobody came. But there has to be a priority where you say, it is important that I know how this medication is going to work, how these procedures work, how these treatments are going to work in diverse populations. And let me tell you, and you need to know that, not because that there is any major genetic differences between black and white women. I mean, we share like 99.6% of our DNA is the same. However, the lived experience of black women in this country is different. And we have to look at the totality of that experience as to whether or not things work or don't work. We need to know when we say, oh, this medication works for you and it doesn't work for someone else, well, we need to know what are the reasons why you don't have access. You know, what about women who don't have insurance? What about women who don't have paid leave? If you're diagnosed with cancer and you have your surgery and you need 6 weeks of radiation afterwards, what if you don't have a car? What if you can't get to the hospital? What if it's inconvenient because that type of hospital and that center is not in your neighborhood? These are things that are fixable. You know, it doesn't require any great, genomic study to figure out what that is. It is just the logistics of why black women in this country do worse. And it's not just maternal mortality. Let me disabuse you of that notion. The same drivers of the poor health outcomes in maternal mortality and infant mortality in this country are the same drivers of increased cardiovascular disease, increased cancer rates, poor outcome cancer. It's all the same. So if you fix one, if you at least address those things, and the biggest, let me say this, I'll say it again, when we talk about bad health outcomes, the things that we can immediately address is giving women access to health care. Because women do poorly and we do worse, not necessarily because you're getting bad care, there's that, but because you get no care. And it is not a coincidence that the states that have the worst outcomes in cancer, in heart disease, in obesity, in maternal and infant mortality, they're in states where women have the least access to health care. There you go. And you can almost map them on the Confederate states in the southern United States. And that is a matter of policy. That's not genetics, it's policy. And people making decisions about who's entitled to what. And, you know, it doesn't have to be but this is where you hold people accountable. You hold, because that is who's in your state legislature. That is who your governor is. That is who is the health commissioner. Those are things that are important. So I don't want to ever give anyone the impression that because black women have poor health outcomes, then it must be something that black women are doing. There's a lot of victim blaming when it comes to things, and it just drives me crazy to see, well, you know, because the conversation often becomes, we just describe it, and we go, oh, it's 2 times this, it's 3 times this, and we go, We don't ask why. There are not enough studies that really investigate it. And more importantly, even when we know, there's a lack of will in being able to do the things and correct those social determinants of health, which are just all the things outside of the person that affect whether or not you have, you know, your access to care and whether you have clean water, whether you have clean air, whether or not you live in a food desert, whether or not you have access to safe outdoor space, paid family leave. All of those things have nothing to do with you as an individual, but everything to do about the decisions that we make as a society.
You know, Dr. Malone, I could spend all evening asking you questions, but I am going to turn it over to the audience. There are microphones. One thing that I will note, keep in mind, you did not pay copay to be here. So if you have individual questions that you would ask your healthcare provider, this is not the place for that, but we do encourage you to make that doctor's appointment and have some grown women talk, okay?
And, you know, and while we're waiting on a question, let me just say this, because I want to give you a little bit of an overlay of what my book is really about and what it intends to do. It gives you the basic logistics, what's changed in medicine, what you need to know, how to assemble your team. And it also tells you what's important about your family history, your health history, how to take care of yourself, how to advocate for yourself when you go in. The point of the book is I'm not trying to turn you into a doctor, but I want you to have enough basic information such that when you are in that situation, you know what questions to ask, and don't be intimidated by someone just telling you something. Know how to show up for an appointment, know how to be prepared. And that's how you're going to get 5 to 7 minutes of FaceTime in front of a doctor, so you better make that 5 to 7 minutes count by being prepared and walking in there loaded for bear, knowing what I came, and don't leave that office until you get what you need.
Is it okay? It's on. Hi, good evening. I have a question and a follow-up. Do you have any opinions, suggestions on healthcare in the educational system? And if so, how young do you suggest that education should be implemented? And how do you suggest advocating for preventative healthcare in the U.S. when women of color are especially far more likely to die because of doctors necessarily being dismissive of their discomforts when it could have been prevented in the first place?
Okay. All right. Now let me make sure I understand. Your first question was
Related to education, so
Yeah, education.
In the policy aspect, one of the things that I firmly believe, I'm interning with the House of Rep right now, and education is the key to everything. If
Right.
men and people in general were properly educated on women's bodies, we wouldn't have the
Right.
things that are going on right
Right.
now.
Right. That is key. Let me just say, because our current medical system is disease-focused. We wait until you get something, and then we try to come up with, okay, I got a new medication, I have a new procedure that's more expensive, more complicated than the thing before. And I think that what we have got to do is, I have advocated for this. I'm like, there are certain things that we know so much about that we should be able to run PSAs about them, because education of the patient means knowing what the signs and symptoms are of things that you should be aware of and when to engage. That's key. Yes, education is very, very important. And I think that once we do that, then we can get to the next phase. And let me say, I cannot say it enough how important prevention is. Because we don't want to wait until something has progressed to the point of not being fixable. And to give you an example of the things that we've been incredibly successful at when it comes to educating the public and giving you the information that you need and giving women access, let's look at cigarette smoking. You looked at cigarette smoking, and people smoked and smoked and smoked, and you finally said, look, we ran campaigns against anti-smoking campaigns, because we said, look, this is what's important, and guess what? Smoking's way down, lung cancer's down, because of a simple, we didn't necessarily come up with some really great treatments for lung cancer. They're better, but the real decrease in lung cancer deaths has really been because of a public education process and making sure that we are doing the things that work on the prevention side. But let me tell you this, doctors don't get paid on discussing prevention. They get paid for treatments and for coming in, and the pharmaceutical industry makes money. They don't make money if you're trying to say, well, why don't you just go exercise? Or why don't you eat a healthier diet? Why don't you do those things? There's no market incentive for those. That's why it's important that the government do it, because there are only certain things that the government is able to do. And we can't count on the market, because they're going to always want to sell you the newest, the more expensive drug treatment procedure. So.
Thank you so much.
Yes. We'll go. You want to go beside that? You'll be next. You'll be next after here.
Hi, sorry. I just wanted to say thank you for sharing all your insights and perspective. It was very eye-opening, but I kind of was starting to think about so I'm a student at George Washington University, and I'm taking a university writing class that focuses on like critical race theory in society and just like racism and inequality in general. And we were just talking this week about like how the racism and like paid family leave, and that I guess falls around like also infant mortality rates, like being higher for like different groups of people. And I was kind of wondering what you would have to say about like policy like changes that could be made around like issues with paid family leave or issues with like adequate health care, and I guess just like racism and health care in general.
Here's a simple thing, and I can say this as an obstetrician because I delivered babies for years. And we get into this mindset of we do it that way because that's the way we do it. No one has thought about it in modern times, I say the last 60 years, as women have entered the workforce. We don't have the luxury. When women used to stay home, all right, so you'd have a baby. What it used to be, you'd stay home, you'd have a baby, your mother was nearby, your aunties were nearby. You had a support system that was built into your convalescence. Well, where are we today? Well, we are now in a situation where most of us who are giving birth we're working women. We do not have the luxury of having family members and people that will take care of us. I was a resident and then a young doctor. When I had my children, I had 6 weeks off the first time, 4 weeks off the second time, and about 4 weeks off the third time. That's not enough time. And we've been doing that to women for an entire generation. We're not taking into account, well, perhaps that's not a good idea, or that's not enough time for you to heal and get back. Another thing that's a simple policy. All right, so let's talk about maternal mortality. 50% of maternal deaths happen between 7 and 365 days after you have given birth. After. So it's not because your doctor was terrible and they did something to you and it's your doctor's fault while you're in the hospital. It happens when you're home. Now, if you don't know, again, it gets back to one of those public education processes. Women are not dying from different things. We're dying from the same things that we've been dying from forever and ever. Perhaps I told you. Perhaps you need another visit, because we used to tell patients, okay, your baby's good, you look great, see you in 6 weeks. That's too long. What if you don't know that, a good percentage of women who even develop preeclampsia will develop it once they're discharged? And we were getting women out of the hospital so quick. You had 24 hours. It's like, okay, bye, with very little follow-up. And these are things that, like I said, these are just policy things that we have to realize that we can't practice medicine in 2024 like it's 1924. Women's lives have changed. Our demands have changed. We don't have child care. All these things, again, and that's policy. And when it comes to women, to black and brown women who are that oftentimes are at the bottom of the at the economic scale, then the imperative to get back to work is even stronger. So that's why I said, yes, we have to look at these things, but we have to look at them from a societal point of view and stop ignoring the simple things around it and not blaming, not saying, oh, if you just had a neighborhood birthing center, that would solve the problem. It won't. It won't. I have no problems with midwives. I was delivered by a midwife. But it's just the way we deliver care and follow-up that's problematic, not just, where you give birth.
Hold on. So, good evening. Thank you so much for having this tonight. So I was taking notes, Dr. Sharon. So I vote, for me, it's a lot of times people don't want to go to the C-kit because it's fear. And right. They don't advocate. A lot of people do not know how to advocate. So I tell people who need an advocate, I say, raise your hand, ask for help. I think a lot of times people are too proud to say that they need help. So that's a big issue. And let me tell you something, Dr. Sharon, that you did not say in this platform tonight. People got to vote. Policy. You just said it. I mean, everybody's sitting up here complaining, well, we don't get it, we don't get it. Listen to what she's saying. Listen to what she is saying. This is made by policy. If we're not voting, these people are elected. If y'all want to sit home, you don't want to educate, you want to advocate, you don't want to connect the dots, we in for a big issue. I just wanted to definitely thank you again for bringing that up. And again, when you go to the doctor, I always have this on my phone. Baby, I'm going with my notes. Because like you said, because I'm running my appointment. The only thing she's doing is listening. I'm running my appointment, period. I'm doing that because, and the last thing, we need to have a partnership with our medical professionals.
Yes.
Period. And collaboration. That's it, that's all. Thank you.
You're okay. I agree. And you know what? We have to, and this is where, in an ideal world, you would have a doctor or whoever you see, even a nurse practitioner or a physician's assistant who has some degree of cultural sensitivity. They have to understand that when you are treating someone, if you want to have the best outcome, you need to treat the whole person within the context of where they live and where they are. And if you don't understand that, then you're never going to get an optimal outcome for everybody. And we also have to deal with the basic things like, you know, there is, just as we talk about systemic racism and implicit bias, medicine is no different. You know, we have a lot of misconceptions. You know, doctors trigger things. You know, we have this sort of triage thing that goes on in our head, and we go, oh, yes, Asian woman this, black woman this. You have already sort of gone through about who gets what, and a lot of times it's because we've been taught things that are not true, or we're using stereotyping when it comes to how we treat women that really is not useful for the individual and really not good for us as well. So we need to educate our doctors a little bit better so they can see and understand that what works for some person may not work for the other. Let me say, and I use this example in my book because, as we said, when we treat things, we can just innovate our butts off. You know, we have got more medications for things, and this is a classic example of how you advocate for yourself. Or you say, wow, this great new medication just came out, and it's great, and it's new, and it's improved. Let me write you a prescription for that. Well, this is what happens. They write your prescription for that. Well, they got some free ones in the closet, or they maybe have a coupon, and they'll give you that coupon, and they'll say, go take this. And you're like, oh, this is great. You take the coupon. All right, that coupon's going to run out. And now you realize that that medication that your doctor just gave you costs 5 times more than the one you used to be on. There is nothing wrong with going back to your doctor and saying, hey, I can't afford this. What is wrong with the medication I was on before? Is there some great benefit in this? And I hate to tell you this, but in most cases, it's not, particularly when you're treating common things. You know, high blood pressure, diabetes. We can come up with more expensive things. That's what we do. But the reality is, do not be embarrassed to say, this copay is too much for me. Find me something else that I can't afford. You know, and I think that nothing sort of exemplifies that more than what we're doing with weight loss drugs. You know, you have something that people can't afford. The people who probably need it the most can't afford it. And again, these are decisions. These are people making decisions about who can get it, who can afford it. There are drug companies that are pricing things out of the market where you can't. And so we've got to, you know, again, this is policy. This is people making decisions about what you can get and what you can't get. Don't be lulled into watching commercials on TV about people dancing and think you need that too. Maybe, maybe not. And if you can't afford it, then you need to leave that and go get something that you can't afford.
Hi, how are you? One, I wanted to just follow up on your comment. I think when we talk about voting, a lot of times people are just thinking during the federal elections. We have to remember that you have to vote state, local, and off your elections because the health departments, you know, where's funding going to go for your health departments? Where are hospitals going to be built? And I think a lot of times we get excited during presidential elections and we forget about these other things that really impact our lives.
Right.
But what I wanted to ask you, I'm of that age now. I'm very good at advocating for myself. I have a 78-year-old mother that I'm trying to, you know, advocate for herself. And she'll tell me things when she comes back from the doctor, and I'm like, well, Mom, that just doesn't kind of sound logical or make sense. I live here, she's in South Carolina. You know, what do I do, or what can I do for her to help her advocate better for herself? I think something like this would be great, you know, for women at a senior center or, you know, things like that. You know, because I think a lot of us, well, I'm way past this generation, but are getting better at advocating ourselves, but it's still dealing with a lot of our elders that are, if a doctor says something, it's got to be true, or
Exactly.
you don't question them. How do you get them past, you know, that point?
Well, you know what? Again, in an ideal world, you know, everybody needs a buddy system, particularly if you are sick. Because when you are sick, when you get a tough diagnosis and you come in to talk about whatever it is you're going to talk about, it's like this. You hear 25% of whatever they said. You know, and if you can't be there, if you can't have a buddy with you to sit there and listen and answer questions and ask questions for the person who can't advocate for themselves, then you just say to them, you know what? Ask your mom. If anybody who's got a cell phone can say, my daughter is in Washington, D.C. Do you mind if I put on conference calls so she can hear what you're saying? Because we are all dealing with elders who, again, may not be capable, you know, just because of, you know, they're elderly, they don't understand, and nothing is worse than for older people to not, if you want to say one of the biggest reasons why people are hospitalized and die is usually medication errors. Because, again, the doctor gave it to me, well, and I give an example of that in the book about how you need to keep, falls to you now, you need to know what your medications are. You need to know what doses you take. You need to, your other doctors, everybody needs to be informed so we're all on the same page so someone doesn't give you something that, you know, conflicts with what you have and you'd say, well, sure, well, they do that at the pharmacy, don't they? Well, sometimes, suppose you got one at Costco and you picked another one up at Walgreens and whatever, and they may not be checking those medications against one another. But the common thing that happens is that particularly when you've got elderly people and they might have 10, 12 prescriptions. Take 2 of these in the morning, 1 in the afternoon, whatever. It's really easy to mess that up. I can't remember between before I took my shower and after I took my shower, I'm like, oh, did I take that? No, or should I? You know, do things that make it easy. Get pill counters. Put them in, you know, things, and there are apps for that. And I put those in the resource section of my book such that you can cut down on the errors. But any doctor who is worth his or her salt should not mind if you just say, look, you know, my mom, you know, maybe she doesn't hear well. Maybe she has, you know, early stage dementia, whatever. And to rather than just send her in with a caregiver, you say, I need to be on the line when you're talking. Just call me, put me on speaker when you're talking to my mother. That's how you can be an advocate from afar.
We're a little over time, but I believe we have time for one more question.
Okay, I just want to say thank you for writing this book and thank you for having this discourse with us. We're appreciative. You spoke to history at the beginning of your talk, and I think that a lot of Black people have a hard time going to doctors because of the history of things that we've gone through. So how do you think, or what do you think providers could do to help Black people face that history in individual, I guess, settings or broadly?
Well, let me say, because I think that we are at a point where the entire medical system is really about to shift on, you know, it may not, it would be great if everybody had a culturally sensitive doctor who understood and all the things I said, but that's perfect. We don't live in that world. We live in a world where we have a doctor shortage. We've got to figure out, this is where we, as Americans, we know how to innovate. And I think medicine is the last foot-dragging, you know, sort of area that has not really incorporated technology and innovation, because let me tell you, artificial intelligence is coming. And to be quite honest with you, a lot of the things, and I don't think that's a bad thing, it's what it is, and it's what it's going to be, because as I say, you have 5 to 7 minutes now. I think that given the doctor shortage that we're anticipating and the number of doctors that are leaving the doctor pool because they're frustrated and overworked and underpaid, and doctors are coming out and they're, you know, for those of you who've seen concierge doctors who are saying, I don't want to see 50 patients a day. I'm going to see 10, and I'm going to charge them 5 times as much. That's where we are. And that works great for people who can afford it, but what about the rest of us? And that's where I said we've got to leverage some technology. We've got to be able to say that, you know what, how we deliver care right now today works for no one. It doesn't work well for you. By the time you've taken a half day off from work, paid to park, waited, now you're mad and you get 5 minutes, and you're sitting there and you're like, ugh, and I ain't even get to my questions. That doesn't work. So we're going to have to, and we can and we will come up with a system where, and that's the only, if there's any good thing that happened with COVID, is understanding that there are different ways to deliver care that are more efficient for you and for your healthcare provider, and that we're going to be able to get more of this information. Why, as a doctor, should I have to say the same thing 25 times a day? Say it once. Look at the YouTube, go video, and get to the end. Any questions? AI, well, you know, you ask your questions, it will answer you. That makes way more sense than what we do now. It's just that we've got to embrace it. And for the young people in the audience, y'all are already with that. You're like, oh yeah, I got it, no problem. It's only for those caught in the crosshairs, those of us who are, you know, in the generation that doesn't really know how to do that. My daughters are more than happy not to go. They're like, oh, text me. Why are we talking? You know? And do you lose something in that? Yeah, a little bit. But remember that each generation feels, you know, of doctors feels that somehow that the generation that comes after them, you know, oh, you don't know anything about how to deal with patients and whatever. I was in med school before you could get a CAT scan. I was in New York City. We had one CAT scan machine in the entire city. So you had to really be justify why somebody could have this really expensive CAT scan or an ultrasound. People would get pregnant. You didn't have ultrasounds. Wow. You were just like, oh, look at that, it's 2 of them. Who knew? You know. But I say that to say, but the technology improves. And do we lose a little bit of the diagnostic ability, you know, that perhaps? But you know, we used to be able to look at people and tell that's still helpful. But it's not a reality for most people. So let's embrace it. And then this is the opportunity, and this is the message I'm going to leave you with. As we make this transition, this puts you more in the driver's seat than you've ever been before. And so if you know what to do and how to advocate for yourself and to know what questions to ask, that's all I ask. I don't ask you, did you know the answer? But know how to ask a good question so you get to the answer. And remember, all of what we're doing in medicine is we're storytelling. You're telling your story to me. I'm going to try to put it together, make some sense of it, and together we should be able to craft a happy ending. But if you're telling me a bad story and it's going around here and whatever, and I don't even understand what your story is, then how are we going to fix it? So be a good storyteller, and your doctor will be able to help you effectively. So, thank you.
Dr. Sharon Malone, thank you so much.
You're so welcome.